Okay? It's very interesting that there's been an increase in the recent literature that's now looking at post-arrest EKGs and asking, when did you get the post-arrest EKG? Because increasing number of studies are showing that the initial post-arrest EKG that's done within the first 10 minutes or so very typically overestimates the amount of underlying cardiac ischemia. That kind of makes sense. What do you do during the code? You're giving epi, you're doing compressions, you're giving shocks. All of these interventions can produce a very ischemic looking picture, and it can take a handful of minutes before the epi and everything else wears off and you get a better look at what's actually going on in the coronary arteries. And if you get that EKG right after you get pulses back, almost invariably you're going to have a really ugly 12-lead EKG, and there's increasing data supporting that concept. Now, this idea about maybe waiting a few minutes after you get pulses back has not yet been incorporated into those studies I showed you 2 or 3 minutes ago. But my guess is that the next time the ACC, AHA, and international guidelines come out and address this post-arrest cath, yes or no, they're going to need to start incorporating this literature and tell you that you should make your decision about whether to go to the cath lab or not based on the first EKG immediately, but usually based on a repeat EKG. In the studies, they said at least 8 minutes later. In my experience, I'm waiting about 15 to 20 minutes later. Because if you get that first EKG within the first 5, 6, 7, 8 minutes or so, it's going to really overestimate the amount of ischemia and make you think that there's something that's probably not there because of all of the interventions that occurred during the cardiac arrest. Again, I really think that's going to have to be incorporated into the newest set of guidelines the next time they address this issue. Now, I'm not telling you to skip the EKG, but that first EKG you get, you're going to want to look for peak T waves and look at the wide QRS. Maybe they need calcium bicarb. You're going to want to look at the rhythm. But in terms of getting an EKG to decide cath or no cath, the initial EKG is very unreliable unless you've waited, we'll say, about 10 to 15 minutes. All right? So again, this was the patient I just showed you. This is the EKG that was obtained. Most everybody raised their hand for this. Here's the same patient after 15 minutes. Take a look at those ST segments. Let me go back again for a second. Here's initial EKG. Look at the ST segments. This is 2 minutes after. Here's 15 minutes after. And here's 30 minutes after. And I showed you this EKG. Nobody wanted to activate the cath lab for this patient. All right? This was 30 minutes after cardiac arrest. This patient eventually went for angiography, and there was no culprit lesion. All right? So it's a very nice example of how that initial 12 lead can really overestimate the amount of ischemia. So I really think that it's worth waiting 10 to 15 minutes and basing your decision on the 10 or 15-minute EKG. I like 20 minutes. They say 8 minutes, so I'm going to compromise, say 10 to 15 minutes. Right? And I think the next set of guidelines are going to have to be incorporating that information as well. So again, key points. The post-arrest EKG immediately after resuscitation will typically overestimate the amount of our ischemia, and it's going to overestimate what you think is actually going on in the coronaries.